This HealthWise broadcast is made possible through a corporate contribution from AstraZeneca and by the Mecklenburg County Health Department and by viewers like you. Thank you.
And welcome to a HealthWise Primetime Special as we're about to give you an update on new treatments for breast cancer. I'm your host, Joey Pop. Breast cancer is the second highest cancer killer in women. Lung cancer is the first. It's estimated that about 213,000 U.S. women will be diagnosed this year alone, and 40,000 will die as a result of the disease. The key to survival, early detection. Stats show when breast cancer is confined, the 5-year survival rate is close to 100%. Our focus with this show is to explore treatments. Our medical panel, Dr. James Boyd of Oncology Specialist of Charlotte, and Dr. Will Warlick from Presbyterian Radiation Oncology. Welcome, gentlemen.
Thank you, Joey.
Thank you. We look forward to a fascinating hour. And we welcome your questions. October is Breast Cancer Awareness Month. Many activities take place, and we'll update you later on where to find them. Also, if you would like a free pink ribbon pin like what we're wearing, free information on how to do a breast exam, as well as a guide to understanding breast cancer, you can call right now a toll-free number, a special number that's been designed for us, 800-972-9451. Welcome to HealthWise, gentlemen. Dr. Boyd, you've been with us many times, and it's always an hour that flies by. There's so many people out there that want to know the latest treatments. Let's first just give an overall view on what we're talking about when it comes to breast cancer and treatment this day and time.
Joe, we're talking about the latest developments that have occurred over the last 5 or so years, and there are many that have occurred in the management of breast cancer, in the local therapy of the breast cancer, and in the treatment to prevent recurrence of breast cancer, as well as better quality of life treatments for those who have advanced spread breast cancer. So we're excited about the new developments. I think we've come a long way, a lot of new exciting developments coming down the pike.
There's hope out there, right, Dr. Warlick?
Certainly, certainly. I think one of the beauties here tonight is Jim Boyd is here and I am here. We're each specialist, and there have been different areas that we specialize to treat women. A surgical oncologist, a medical oncologist like Dr. Boyd, or a radiation oncologist like myself. We each are bringing something to the table that is trying to design the right treatment for that patient so that they can have the best quality of life and have the best chances of success.
Okay, let's go ahead and explore that. Here you are a radiation oncologist, medical oncologist. What's the difference?
Yeah. Well, generally, when a patient has felt a mass in the breast or has a abnormal mammogram, they will see a surgical oncologist, preferably a breast surgeon who specializes in this area and this disease. They will biopsy them and then talk about local treatments with surgery. And that's either allowing them to preserve the breast or remove the breast. Radiation is an adjuvant. It's an additional treatment to work with surgery to try to sterilize the regional disease, either the remainder of the breast or other lymph nodes. And then Dr. Boyd is a medical oncologist who will talk to them about systemic treatments, treatments with chemotherapy, hormonal therapy, or the newer agents, which are these newer biologic agents that we're all excited about.
Well, so as you can see, we are talking about the treatments, and these men here will be welcoming your questions at 704-371-8895 during this hour. But first, we have some visuals we'd like to share with you. Let's just talk about the breast in general. When someone is told they have breast cancer, what does that mean? And let's go to graphic number 1. Dr. Warlick, if you'll explain to us what we're looking at here.
Yeah, this is just a cross-section of a woman's breast, and it is showing the different elements of the breast. The breast is mainly made up of lobules. Those are actually where the milk is produced, and then the duct system, which takes the milk out to the nipple area. The lower section is what one of these ducts appears to be. And a breast cancer can either form in the lobules or in the ducts. The most common cancer is ones that arise in the ducts. When we're here talking tonight, we'll be talking about concerns with invasive breast cancer, and that's one that actually started in the duct or in the lobule and then got outside to the connective tissue. That's the yellow or the fat in the breast. And once it's taken on an invasive characteristic, that's a real cancer. Many women will have what's found on mammograms to be a cancer still confined within the duct, and that's a more favorable prognosis. And so we have to sometimes work, educate those women that these are sort of precancerous lesions. But those are sort of the basic components of the breast and where the cancers can arise.
Let's go to graphic number 2, and I believe this is a mammogram. On the left is different from a scan on the right.
Yeah.
What's the difference here?
Yeah. Well, this is something that we are looking at now. As you mentioned earlier, Joey, the real importance of mammograms and early detection. And mammograms are an excellent tool, but they still leave something to be desired. You can look on the left and see that's a typical mammogram. And now on the right is one of the newer computer-assisted, sort of an enhanced digital mammogram. Now, this is actually something that will be coming out in the near future, and it really is in the process of being approved through the FDA, called a tomosynthesis. And what that does is it enables the mammographer or the radiologist to really pinpoint on these areas and to bring out and really enhance those individual lesions. And you can see a pretty clear difference here. The next slide is a similar slide. It will go over the same type of issue where you can see how much more characteristics you can determine from the cancer itself. You can get a better understanding of the extent of the disease, and that helps the surgeon try to select what's the right way to manage this surgically.
And then the next slide, I believe you have an MRI for us.
And we can get into this. This has been one of the newer areas that's been utilized over the last several years to help us truly define the extent of the disease. Now, this is on the left is a sagittal slice that's looking through the breast from the side, and the one on the right is looking at it from above. And
Looking straight down.
Looking straight down. And so as you can see on that right side, there is a mass, and we have a much better understanding about the extent of the disease, so we can decide, is that woman, can she undergo a breast conserving surgery and radiation, or would she be better served with a mastectomy, with the removal of the breast?
What's the white areas in this test?
So that's just a portion of the normal breast architecture. And on the right side, and it's a little more washed out on this particular area, but that solid white area is the actual tumor, and that's showing some enhancement characteristics so that the radiologist can decide, is that cancerous, malignant, or is that more benign process with a normal breast?
Let me make sure I understand. The more oval shape that we see, whether it's on the left or on the right, more to the left is the cancer?
Is the cancer,
okay,
yes.
that's the cancer.
Yes.
All right, Dr. Boyd, let's get you involved in the discussion. The next slide, I believe, different types of targeted therapies. What the heck is this? You need to tell us in detail.
Targeted therapy, people have made the analogy between targeted therapy and smart bombs versus area bombing, where you damage a lot of collateral buildings and people. With targeted therapy, these are molecules that can be antibodies, which are shown here, or they can be small molecules that actually interfere with the normal processing of cancer cells. That is the signaling, that the impulses that tell that cancer cell to grow, to divide, to spread. These specific proteins will target those enzymes, those receptors that cause cancers to develop and grow.
What am I supposed to be looking at here?
What you're supposed to be seeing, if you look at the center, that sort of turquoisey pink thing is an antibody. That's an antibody to a small molecule. You can see they're attached to the two arms, and below that it's a little molecule attached to, between the two tan structures. This is an antibody to a protein that causes blood vessels to grow into cancer cells and feed cancer cells. And by blocking or binding to this molecule, this is a way to maybe prevent cancers from getting their blood supply, and in effect starving cancers of their nutrients, making chemotherapy more effective. So this is a way to it's called anti-angiogenesis, blocking the blood vessels that feed cancer cells.
Now, when we talk about targeted therapies, are we talking about conserving the breast, or is it still on patients who have had a total mastectomy?
Targeted therapy is a systemic therapy. It's mainly for women who have had spread of their cancer to other organs. And cancers that spread need to bring in their own blood supply. Otherwise, they die. And so in this situation, there's a molecule that actually the cancer makes that draws in its own blood vessels. And these antibodies can inhibit or block the ability of these small deposits of cancer in different organs from bringing in their own blood supply, and in theory, can starve the cancers.
Give us some examples of some inhibitors, some names that perhaps our viewers will be familiar with.
In breast cancer, there are two that have been approved. One is a drug called Avastin. That's the picture we saw of this antibody blocking a molecule stimulating blood vessels. That has been found to be effective in women who have had spread of their cancers to other parts of their body.
And once it spreads, what stage are we talking about in cancer?
Well, it's advanced stage. Certainly if a woman presents with spread, stage 4. If a woman presents with early stage, but 2 years later it crops up in her liver or lungs, that's just called metastatic disease, metastatic to bone or liver. And we have to treat it with medicines that go to all the parts of the body that can attack these areas that have spread, that have brought in their own blood supply. So that's a drug that's been effective in making chemotherapy kill cancer cells that are in other parts of the body. Another targeted therapy is a drug called Herceptin, which is effective in two conditions. One is if the cancer has spread to another organ. This drug, Herceptin, which is another antibody, is effective in those 20 to 25% of cancers that have too much of a receptor on their cell surface called HER2. That protein makes these cells more aggressive.
I think we may have a slide to that. Let's go to, I believe it may be slide number 12, if not 13. Let's just go ahead and bring one of those up and see which one it is. And Dr. Boyd can tell us. Yeah, it's coming up in just a second. But first off, you were talking about stage 4 cancer. The stages go up to stage 5, and these drugs are helping women live in stage 4 and stage 5?
Well, actually go up to stage 4, and it's helping them live longer in stage 4 metastatic disease. What you see here, Joey, is actually a diagram of the blood vessels that feed into cancer cells. On the left, there's a small cancer. It's just spread to an organ such as the liver or the lung. It's small enough that it can get its nutrients from surrounding tissues. But when it gets bigger, it needs to bring in its own blood supply, as you see on the right. And what we hope to do with these antibodies is to block that or impair that formation of blood vessels that feed the growth of these growing tumors.
Now, once the tumor is large on the right, do these inhibitors actually help shrink it?
They do, but more importantly, they make the chemotherapy that we give patients access or get into the tumor more effectively, and therefore are more effective in killing the tumor. So it has two roles. One is it inhibits blood vessel formation, and the other is it enhances chemotherapy killing effect on cancer cells by allowing the chemotherapy drugs to get more effectively to the cancer. So that's one form of targeted therapy.
I think we have slide 13, and it shows the Herceptin, I believe. So there is not a 13. Okay. Let's go back up then to the next slide if we can. I was thinking that we had a slide that had the HER in there, but maybe we'll see that in order as we go. So let's go to the next slide that we had in order if we can. Breast conservation trials. What does that mean, Dr. Worley?
Yeah, Joey, what this is going over the trials that had compared mastectomy, the removal of the entire breast, to breast conservation, where the surgeon would remove only the tumor and add radiation to sterilize any microscopic disease. Joey, I think it's good to sort of take a step back and look at these. These are trials that were done with women in the 80s and early 90s. And we now have follow-up out to 20 years, and we're showing a substantial reduction in the recurrence in the treated breast when we add radiation therapy. And I think these are the benchmarks which we have to compare newer therapies to, that we show when they would remove the tumor itself and not add any radiation, that the recurrence rates were in the order of 25 to 35%, but that radiation significantly reduces that. So over the next 10 years, their recurrence rates are on the order of 5 to 10%. And that's a very marked reduction. That's, you know, and when you look at it relatively, it can be a reduction of 60 to 80%. So I think this is showing what our benchmark is. This is what we need to, you know, still hold up the high standard of care with some of these newer techniques. And this gets back to sort of, this is addressing the local issue, the surgery and radiation aspects, where Jim was referring to the systemic treatments, either the chemotherapy, endocrine therapy, or those new targeted therapies.
All right, and we're going to bring up the next slide, and then we're going to start taking some phone calls because we are getting a full phone bank, and that shouldn't be surprising. Let's go to the next slide. Is this another, is this a scan?
This is a CT scan, and it's a cross-sectional CT scan of a woman's chest and then her breast tissue. And that's actually the breast on the top half of that slide.
So we're looking down. We're looking straight down on the body, correct?
You're looking down on the body. And so you can look in the center, and that's the center portion of the chest, the heart and the lungs. And then this is the breast tissue that's sitting on the outside.
On the right-hand side, that's outlined.
Yeah, that's the outlined area. And when you look at that, those are actually radiation doses that is being delivered to that breast. So this is what is really the new cutting-edge treatment for breast cancer, for breast conservation. In the past, we would do standard tangents where we would treat one from the inside and another from the outside to cover the breast tissue. We can now use what I consider 3D conformal techniques to modify that. Or this particular diagram shows IMRT, intensity modulated radiation therapy, where you can see those different colored lines. They are being pulled away from critical structures, away from the heart and away from the lung, and only addressing the breast tissue. And I think that is really helping us with long-term issues with these women. We're still going to have excellent control rates, but that we're going to reduce the long-term side effects associated with it.
Is that considered another targeted therapy?
It's not targeted. It's still a regional treatment. I think when we use the term targeted therapy, we're really talking about very select aspects on the individual cell that these agents can be given and can go out and to target those regions. Mine is still a regional therapy. I just think it's a much more sophisticated way to deliver the radiation to the breast, and that's where I think we'll make some advantages.
I should mention targeted therapy is not a new thing. Target means targeting that thing about that aspect of the cancer that is unique to the cancer and making the cancer grow. Hormone therapy, tamoxifen, has been around a long time, and now these new aromatase inhibitors target the estrogen feeding capacity of these cancer cells. And about 70% of cancers are fed by, breast cancers are fed by estrogen. So blocking the estrogen or removing the estrogen really helps shrink and kill these breast cancers. Targeted therapy for breast cancer goes back to the late 19th century. It's been around a long time, but we've become more sophisticated with it. We have better treatments in terms of removing the estrogen that feeds breast cancer.
You brought up hormonal therapy. Is this day and time, we've heard some negative response to hormonal therapy. Is that true?
Well, when I refer to hormone therapy, I'm not talking to hormone replacement therapy. I'm actually...
And that's what's been controversial,
right.
Correct?
I'm talking about drugs that actually block the effect of hormones like estrogen, or namely estrogen, in feeding cancer cells. Now, tamoxifen has been the old standard, and there's some controversy about tamoxifen because it does have some estrogen-like effect, but its role is blocking the estrogen feeding breast cancers. That's still our #1 drug in premenopausal women with breast cancer that's estrogen fed. But in postmenopausal women, we have at least 3 new drugs that really suppress the estrogen in a woman's body that feed cancer cells. And these are called aromatase inhibitors. And they're more effective than tamoxifen and have less side effects than tamoxifen.
All right, let's take some calls, shall we? We have Sue from Charlotte. Welcome to HealthWise.
Hi.
Hi.
If you've had several lymph nodes involved and your treatment was about 10 years ago, could you feel pretty confident in that you're cured?
It's been 10 years and you've been a survivor.
Right.
Okay. Is she cured?
That's a good question. Breast cancer can recur late, that is beyond 10 years in certain women. Generally, these are cancers that are estrogen fed, they're slower growing, and so over a 10-year period of time, due to the slow growth of the cancer, they can remain somewhat dormant and then come back later on. For faster growing non-estrogen fed cancers, generally if you make 10 years, you're probably not going to have a recurrence.
Congratulations, Sue.
Thank you.
You have a follow-up for us? Okay, let's go to I believe it's Diana from Gastonia. Deborah from Gastonia. Hi, Deborah.
Hey, how are you?
Good. How are you?
Fine.
Your question.
My question is to Dr. Boyd. I am a twice breast cancer survivor. I had a bilateral mastectomy, and I'd like to know what type of preventive measures I should have in place at this time.
Preventive measures. Dr. Boyd?
That's certainly a good question. You've had bilateral mastectomy, so obviously we don't have to deal with mammograms at this point in time.
That's correct.
It depends on the type of cancers you had, whether or not they're estrogen-fed or not. Certainly, in estrogen-fed cancers, we do give anti-estrogen pills like tamoxifen or other newer pills that do help prevent a recurrence. Usually they're given for 5 years. There have been some studies recently that actually show that women who engage in exercise and a low-fat, healthy, high-vegetable diet, referred to as the WINS study, actually have less recurrence if they adhere to those healthy lifestyles.
Deborah, thank you so much for the question. We were talking about that there could be 40,000 deaths in this country involving women this year alone. Almost a 250,000 women will be told they have breast cancer. But what we didn't say is that there could be more than 1,200 men in this country with breast cancer.
Yes. And people don't, well, some people don't realize that men can get breast cancer, and there's certain risk factors for men getting breast cancer. It's about 1 man per 100 to 150 women.
Whereas it's 1 in 8 women with breast cancer, correct?
Correct.
Yeah. 1 in 100, did you say, for men?
The incidence of breast cancer in men is about 1% of what it is in women.
Okay.
So it's not common, but we see several cases a year in our practice. It is generally treated like women's breast cancer. That is, we don't deal with breast conservation, but we have the surgeon do a mastectomy, check the lymph nodes, do the same staging, and stage per stage treat with the same chemotherapy and the same anti-estrogen therapy. More male breast cancer seems to be estrogen-fed than female breast cancer, so we're often using anti-estrogen medications with it.
Well, we have a caller on the line. Her father has breast cancer, I understand. Tina from Charlotte. Welcome to HealthWise.
Yes, sir. Thank you. I was just curious as to, since my father was diagnosed with breast cancer about a month ago and has had surgery, what precautions do I need to take? Now, I do go to a breast specialist twice a year. I've been doing that for years. I have the ultrasounds twice a year and a mammogram once a year. And my father did go get genetic testing the other day, but what do I need to do?
Right, because you're concerned with the role of heredity. Okay,
yes, sir.
Let's see what the doctors have to say.
And he's 78, by the way.
He's 78. Can we ask your age?
Yes, sir. I'm 49, just turned 49.
Okay, let's hear what they have to say.
Thank you.
Well, we do know that there are hereditary breast cancers, the BRCA1 and BRCA2 genes, which are easily tested through a lab test on the blood. Fathers can actually carry these genes and give it to their daughters. I think if your father tested positive, you would have to make a decision whether or not you would want to be tested for the gene. And if you tested positive, decisions have to be made about how will you be followed. Some women have to struggle with the decision about having both breasts removed. Often there's a connection with ovarian cancer, and they have to make decisions about having their ovaries out if they test positive for the gene. If your father does not test positive, then we generally say it's probably a sporadic or random thing, not familial, that you should have your usual follow-up like you're getting now. Actually, you're getting a quite close follow-up.
Okay.
And I would not change anything that you're doing.
Sounds like you're doing the right things. Thank you so much, and good luck to your dad, Tina.
Well, thank you so much. Bye-bye.
She mentioned genetic testing, and we have a question about that now from Linda. Hi, Linda.
Yes, I've had a double mastectomy, and I was concerned about and wondering what the doctors thought about genetic testing. I have 2 daughters.
Okay, so you're concerned for their health, correct?
Yes, sir.
Okay. Dr. Warlick, you want to take
Well,
that?
I can touch upon this. I think, the genetic testing has certainly taken off, and I think it is something that we are certainly looking at in women. But we have to remember that the majority of breast cancer are sporadic cancers, as Jim was talking about earlier. And so we are looking for other connections, whether there's first-degree relatives that have breast cancer, if there are younger women, premenopausal, that have breast cancer. Those are the ones that have a closer association with the genetic testing. Testing positive for one of at least the two known ones, BRCA1 and BRCA2, is still low. It's still only about 10% of breast cancers. And so I think the one thing that we always have to look at is try to look at the family pedigree. And there are issues where you would meet with the geneticist to really discuss how much at risk are you? Do you need to go through and do the genetic testing? It does carry some expense. And there are issues that we have not fully worked out as a medical community or as a societal issues related to what happens when you are tested positive about some of the other issues. And so those are always things that you really need to sit down and have some long discussions with the geneticist and your local, whoever your physician is caring for you.
Linda, thank you so much. Dr. Boyd, I think you had something to add with that?
Only that there are probably other genetic problems that we haven't discovered yet. There's BRCA1, BRCA2, there may be 3, 4, and 5. And so it's certainly reassuring that if you or a family member test negative for these genes, but it doesn't eliminate completely the risk of a familial breast cancer gene that we just simply haven't discovered yet.
Linda, thanks. Let's go to Rachel here in the Queen City. Hi, Rachel. Rachel, you with us? Okay, I think we have Ed now. Ed from Charlotte. Hi, welcome to HealthWise.
Hi, thank you. A question for Dr. Boyd. He talked about the Avastin being effective. The question is it effective for HER2-negative breast cancer patients?
Dr. Boyd?
The question is with Herceptin, is that?
Did you say Herceptin? Yes.
The Avastin.
Avastin.
Avastin, yeah. That's the one that blocks blood vessels, also known as bevacizumab, but it's easier to say Avastin. It is effective in all types of breast cancer that has spread to other parts of the body. It does improve or reduce the progression over chemotherapy alone when you add it to chemotherapy for about 5 months. So it is an advance, and so we do think it's effective whether it's estrogen-fed breast cancer, estrogen-not-fed breast cancer, whether it's HER2-positive breast cancer or HER2-negative breast cancer. It seems to be effective in all categories.
Ed, you have a follow-up?
No, that's it. Thank you.
Hey, listen, thanks so much for tuning in tonight. You know, I had said earlier stage 4 to stage 5, and you were quick to correct me that there's not a stage 5 in breast cancer. And we have a caller about the stages. So let's go ahead and hear from Mary from Charlotte. Hi, Mary.
Hi.
Your question.
Yeah, I'd like to, you sort of just jumped right into things, I think.
Yes, we did. Boy, we went right into this topic.
Discussing complicated grafts and that type of thing. But could we get back to some of the basics and just talk about the different stages of breast cancer and what takes place in those stages? Thank you.
Yes, we were really on a roll, weren't we? We were so excited about talking about new treatments. Let's talk about the stages of breast cancer. Dr. Boyd, let's start with you.
Well, there are 4 stages. Most cancer staging systems have 4 stages, and Dr. Warlick can correct me on some of these too, since he deals with early stage breast cancer also. But we stage breast cancers to predict, or any cancer, to predict the risk of recurrence. We stage them to also guide us in our treatment. Obviously, if something is stage 1 in the situation of breast cancer, stage 1 is a cancer that's 2 centimeters or less in size without lymph node involvement. That's very early stage. We say stage 2, they break them down into 2 categories, A and B. 2A is if you're above 2 centimeters, 2B is if you have lymph nodes. And then the staging goes up. The more lymph nodes you have, the bigger the cancer in the breast. It could be stage 3. Stage 4 is when a cancer spreads outside the regional lymph nodes to other parts of the body. Stage 4, it means it's spread to the bones or to the lungs or liver or brain. Obviously, the higher you go up on the stage, the more risk there is of dying of the cancer, the more difficult the treatment is. With early stage, for example, stage 1, A woman may only need a lumpectomy and radiation therapy and may not need any chemotherapy or anything else. So it does help us, help guide our prediction of how well a woman's going to do and guides our treatment, how aggressive we should be with our treatment.
Dr. Warlick, would you like to add to that?
No, I think Jim laid it out. It is a complicated system where you put it, in different categories. But what I would tell you is sort of stage 1 and 2 are early stage breast cancers. Stage 3 and 4, or stage 3 is more of a regional breast cancer, one that started to spread to the lymph nodes and has a very significant amount of lymph node burden. And then a stage 4 is one that's metastasized. My radiation therapy is used for generally earlier stage women we're trying to preserve their breast, or we're trying to act aggressively in the regional area by sterilizing the lymph nodes with the radiation. Chemotherapy and endocrine therapy are used through all courses of them, but generally the earlier stage ones may need very limited treatments with limited surgery, more limited radiation, and then perhaps just a pill, hormonal therapy.
And were we correct at the top of this show that if it's confined, that the survival rate is almost 100%?
Well, I think the survival rate is certainly going up. Clearly, when you look over the last decade, breast cancer, the mortality from breast cancer has dropped 1% each year. So now that the survival rate is about 10% higher than it was previously, and that's related to mammograms, early detection, it's related to better therapies. Clearly, we are making very strong inroads into curing women of cancer and improving their survival. Stage 1 is a very favorable survival, 90% plus. I wish we had 100% in anything we do, but sometimes there's always outliers.
Well, one of the websites that I did my research in, they were quick to say that.
Yeah.
On the
well, and early stage 1, we could be talking about 5-year survival of 98%. So they're very high.
Okay.
But you still need to follow those women out, for 10 and 15 years because there still can be some recurrences.
All right, we have Rachel. She's back with us now. Rachel, your question for the medical team.
Yes, my sister had breast cancer. She got it at 38. She died at 42.
I'm sorry.
And thank you very much. And she was big-breasted. I'm a single woman, and I've had a lot of cysts that have been aspirated, and also a lump that was, surgically taken out. But I just wondered what my odds are as far as getting cancer, and I have 2 other sisters in the family. And the other question I do have is, have you ever heard of the sister study?
The sister study. Okay, we're going to let you take your answers off the air, and let's first address, she has concerns for risk. Let's first lay out the risk for breast cancer.
Well, there's several risks for breast cancer. One of them is just being a woman and having breast. That is, there's a 1 in 8 chance of having breast cancer develop. Other risks include family history, particularly a family history with a sibling who is premenopausal, younger than 50, developed breast cancer. If a parent developed, a mother developed breast cancer, those are the familial risks, related to the family. Other ones are related to the hormonal cycles, about women who, when they first go through menarche or first start having their period, when they have their first child, if delayed childbirth can also slightly raise the risk of breast cancer. And if they have a late menopause, all those areas where they have, different estrogens on board for longer periods of time. There's also some increased risk that we are seeing now with additional, as we touched upon earlier in the show, additional estrogens that have been given to women for hormone replacement, that people who are on prolonged hormone replacement, there also is a slight increased risk of that. Given her large breast and the other cyst aspirations and biopsy procedures, those also slightly increase the risk. And I think she needs to continue to do the things she's doing, being closely followed with self-examinations, with mammograms, and have her see physicians so if those cysts do occur or arise, they can jump on that very quickly.
Dr. Boyd?
Dr. Warlick hit the high points. There is a model called the Gale Model, and we have shown that in women who don't have breast cancer but have risk, as Dr. Warlick mentioned, certain interventions may reduce the risk of having breast cancer. The drug tamoxifen for 5 years can reduce the risk in these high-risk women by about 50%. Recently, there was a study in postmenopausal women comparing a drug called Avastin, which is also known as raloxifene, to tamoxifen, and both of them were equally effective in preventing the invasive type of breast cancer. So there are, in women who are at high risk, there are some interventions that can reduce their risks.
Very quickly, we need to go to our break, but have you heard of the sister study that she asked?
No.
You're not familiar with that, Dr.
Yeah, I'm
Warlick?
not certain about that. I mean,
Okay.
it may be something with the family history about seeing one develop breast cancer and following the second one closely. There's been a series of trials looking at family members like that.
We're going to take our break. You're enjoying a special HealthWise right here on WTVI. We'll be right back.
This HealthWise broadcast is made possible through a corporate contribution from AstraZeneca and by the Mecklenburg County Health Department and by viewers like you. Thank you. If you would like more information about the guest on this HealthWise program or like to know more about next week's topic, please call the HealthWise information line at 704-371-8836. Email us at healthwise@wtvi.org or by regular mail. HealthWise, care of WTVI, 3242 Commonwealth Avenue, Charlotte, North Carolina, 28205. If you would like support group information about tonight's topic or any HealthWise topic, call Support Works at 704-331-9500. If you are interested in being a guest on HealthWise or like to sponsor a HealthWise program, please call Suzanne Milkey at 704-372-2442.
Learn more about HealthWise and other local productions at WTVI.org. Go to our website and you'll see current and upcoming events on air and in the community. That and much more at WTVI.org.
Welcome back to HealthWise. We're offering an update on new treatments for breast cancer. And with us, Dr. James Boyd of Oncology Specialist of Charlotte and Dr. Will Warlick from Presbyterian Radiation Oncology. If you would like this nice, neat pink pen that we're wearing here on set, free information on how to do a breast exam, it's right here in this brochure. Well, you're certainly welcome to call a toll-free number that's been set up just for this show. It's 800-972-9451. And of course, if you call from a landline, you'll have to dial that 1 in front of it, 1-800-972-9451. Fascinating first half hour of the show. We went right into the new treatments. And speaking of the radiation treatments, Dr. Warlick, that we were talking about earlier, what's the role of radiation in the elderly?
Yeah. Well, radiation's, breast cancer, the incidence still increases as you get older. And so we are finding numerous women with breast cancer as they're older. It is still treated the same way. We still will do the same surgical procedures where we remove the tumor if it's an early stage and add radiation to the whole breast. We'll still talk about chemotherapies, and I think it's important to know that a lot of the chemotherapies can be tailored to more elderly patients to try to select the right form of treatment that's not going to be too hard on them, but still give them the best chance of cure. One of the issues that is coming up now is we are doing so well with breast cancer. Are there certain women that are so favorable where we may not need to add additional radiation treatments? And there have been numerous trials over the past several years that have tried to address this issue. And I think what they are showing is that the women and the recurrence rates in the elderly patient is probably less than it would be in a younger patient, but that there is still a benefit from the addition of radiation. Now, we always have to factor in other issues with the woman. If there are other medical problems like very severe heart disease or very severe lung disease, and likely something else may come up before that breast cancer recurs, then there are some women who are over 70 who have a small tumor that is generally favorable and has an estrogen receptor positivity, so we can talk about tamoxifen, where we may forego the radiation treatments. But I think we have to be careful, Joey, in that when you look at the different actuarial numbers for Social Security, a woman who reaches the age of 70 still has an average life expectancy of 15 years. Someone of 80 still has a life expectancy of 8 years. And so we always have to be careful not to try to cut too many corners short when there still is considerable time left in that person's life and try to allow them to be cured of it.
I had an interesting conversation today with a friend who has an aunt who's 78, 79 today. She had mastectomy 51 years ago and did not have any post-therapy. She did not have chemotherapy or radiation. Apparently they didn't do that then. Times have certainly changed, haven't they?
Yeah, they've changed. I think our outlook in breast cancer has gone through a series of evolutions. I mean, there was a period of time where they would do a very radical surgery because that was all they really had, where they would do the mastectomy and do a pretty extensive surgical procedure. Then there came a period through the 70s where they said, this is a systemic disease. It spreads to the lymph nodes, spreads to other areas. And we sort of backed away on some of the aggressiveness of the surgeries and started enhancing additional systemic treatments. And as we come back around, we find it somewhere in the middle. There's always there's some local disease that needs to be addressed locally with surgery and radiation. There's ones that are systemic that we have to add the chemotherapy. But clearly there are certain women, and that's wonderful for her, that she was able to be cured with this surgery 51 years ago. That's quite remarkable.
Our next caller has a question about post-therapy. We have Brenda from Charlotte. Hi. Welcome to HealthWise.
Hello?
Yes, your question, please.
My question is, I have a friend who had breast cancer, and it was removed, the whole breast was removed, but the cancer had spread to her lymph node. And when they removed the breast, they did a reconstruction at the same time. However, she was not offered either radiation or chemotherapy. So I was, is that normal? Is that to be expected?
Okay, did you say she was offered or was not?
She was not.
She was not offered either one. Dr.
Right.
Boyd?
I'm sorry?
We're going to let you take your answer off the air. Thank you.
Okay.
Dr. Boyd?
This patient apparently had a mastectomy, had lymph nodes involved, which would put it at a higher stage, at least a stage 2. And we feel that that's high enough risk that we routinely offer a woman chemotherapy, and if it's hormone receptor positive, some anti-estrogen therapy. So I would consider the standard in this situation to give that woman something that would reduce the risk of spread of the cancer. And that would be chemotherapy, particularly if the lymph nodes are involved, and if it's estrogen-fed, an anti-estrogen pill also.
Let's go to Linda in York. Hi, Linda. Welcome to HealthWise.
Thank you. I'm calling to ask about my 32-year-old daughter who has her first child, 6 months old, and she has just recently noticed a change in her breast. They did 2 ultrasounds 2 days ago and also a mammogram. As of yesterday, she had a biopsy of the breast and of the lymph nodes, and they stated to her that there was a 3-centimeter calcification. Could you please clarify exactly what that is and the possibility of a malignancy?
Thank you so much for that question. I know you're concerned.
Yes,
Who wants
I
to
am
take
very
that?
much.
Dr. Warlick?
I can talk about it. I mean, I think there's a great deal of concern about those areas. Calcifications are areas that are seen on the mammogram. That does not necessarily mean that it is a breast cancer. I think it sounds like they are doing the appropriate things. They are doing the right workup. They're doing the mammograms. They're doing the ultrasounds. Because you have to remember when women are going through pregnancy and if they're breastfeeding, there's lots of changes going on in that breast tissue. Certainly if there are lymph nodes that need to be looked into, they're doing the proper things. And then once you find the diagnosis, then you can decide what's the best course of treatment for her. And they can, her physicians sound like they're doing the appropriate things, Joey.
And she lives in Seattle, so I'm sure that she will get the top-notch doctors there, hopefully.
Oh, good.
Thank you so much, Linda. And we're going to go to Sylvia over in Wingate. She has a follow-up to Linda's question, I believe. Hi, Sylvia.
Hi, how are you?
Good. How are you doing?
I'm fine.
Your question.
I had a mastectomy October 2005. I had a mammogram. I had went a couple of years, but every mammogram I had was clear. And I had a mammogram, and they had to give me an ultrasound afterwards. And, well, I had it, and then I had to go to the hospital and have another mammogram and ultrasound, and they told me I had to have a biopsy because I had calcifications, 2 spots in one breast. And so she said it looked kind of
suspicious?
Questionable. And so when I had my biopsy, it was carcinogen. It was malignant. And so I opted for a full mastectomy. And he took lymph nodes out from under my arm. I don't have any feelings left under my arm now. And they said sometimes they never come back. But I opted not to have any kind of treatment because the doctor said they tested all the tissue that they took out and all the spaces around it was free. But I just wonder why they don't let people know that they can have breast cancer from calcification besides lumps.
Thank you so much for your insight here. Would you like to respond?
Well, I think that addresses somewhat of a follow-up question that first caller
Linda.
in there. That, the calcifications are areas that are seen on the mammograms, and that's what they can use to determine if they need to biopsy them. Many times the calcifications are coming up from these precancerous areas, or DCIS, another term for it. But those are things that have to be followed. There are benign calcifications that mammographers can follow and say everything looks okay, and then there are ones that have a more worrisome picture to them, and those are the ones they have to biopsy.
All right. Thank you so much, Sylvia. What is
inflammatory?
Inflammatory breast cancer? I understand that's a real growing concern. Is it not?
Well, I don't think it's been around for quite some period of time. Inflammatory breast cancer is a breast cancer that does come up rapidly in women. It will have a component in the skin, and it'll take on a red appearance.
Like a rash, right?
Yeah, a very inflamed appearance. And inflammatory breast cancer can be aggressive, and it can also systemically spread in a rapid fashion. So the primary treatment for inflammatory breast cancer is to utilize chemotherapy early up front to try to take care of any systemic disease, and then come back once you've got regression of the local area. And in those cases, we do not do breast conservation. We'll remove the breast and then add radiation afterwards to try to sterilize any cancer cells that could be left in the dermal lymphatics, or that area of the skin. But we are seeing that we still can cure these patients, but they just have a more aggressive onset, and they need to be addressed aggressively as well.
Is it rare?
It's not, Joey, it's not that common. We see, several cases a year. It comes on fast, and often it looks like it's an infected breast. And there can be a period of time where that woman would get antibiotics for an inflamed or infected breast, but it doesn't get better. And then workup is done, and a breast cancer is found. It can respond quite dramatically to some of the newer treatments, shrinking it down, getting rid of that inflamed redness. Surgery can be done, followed by radiation, and people can be cured.
Let's go up to Mooresville. We have Mary with us. Hi, Mary. Welcome to HealthWise.
Hello.
Hi.
Hi.
Your question for the team.
I had a radical mastectomy done 33 years ago, and I think they removed 4 lymph nodes, and no treatment afterwards. They didn't do it then. But I always wondered, they said I had a cherry pit-sized tumor. How would that be explained in centimeters?
And once again, when did you have your surgery?
33 years ago.
Okay. Thank you, Mary.
Okay.
How would that be defined this day and time?
I'm trying to think of the size of a cherry pit.
Well,
that's probably stage 1. I would put that as stage 1 if the lymph nodes are not involved. Yeah.
Okay. Mary, I hope that helps. Yeah. We have Belinda from Charlotte. Hi, Belinda. Welcome to HealthWise. Hi.
Yes. My question was, if you have really large, dense breast, and I have had also calcifications, it's been quite a few years ago that in my left breast that had to be treated. They thought they were maybe some kind of milk duct problems, even though I wasn't nursing at the time. What is the best way to go about having a breast exam? I mean, what is the best mammography to have done?
Thank you for the question. We'll let you take it off the air. Who would like to take that?
Well, I can address that. The best mammography is just a good standard mammography along with added ultrasounds. When the breast tissue is dense in younger women, I think ultrasound can be very helpful. Some of the newer digital mammography helps with women who have very breast dense tissue. I hope that the tomosynthesis, some of those slides that I showed earlier, which will be coming down the pipe in the next several years, will also help us. MRIs may play a certain role with that as well, but I think that's really being is a little bit out there as far as screening, and is mainly used once a diagnosis of malignancy has been had.
Thank you so much. We are going to go up the road now. We have a couple calls from Catawba and Lincoln counties. Let's first go to Newton with Sharon. Hi, welcome to HealthWise.
Hi, how you doing?
Good, how are you?
I'm good.
Your question.
My question is basically, when does treatment stop? If it's been over 5 years and all your follow-ups have been good, like the blood test and the mammograms.
When is enough enough?
Yes.
Good question.
Thank you.
Dr. Boyd.
Well, there are 2 components. That when does treatment stop and when does follow-up stop? Most of the time we give chemotherapy goes on for a very short period of time, relatively speaking, 3 to 6 months. But anti-estrogen therapy, or what we call hormone therapy for estrogen-fed cancers, may go on for 5 years. And actually, there are studies that go on for 15 years now for those estrogen-fed cancers.
And we're talking about
tamoxifen, or one of these newer drugs, aromatase inhibitors. There are 3. There's Arimidex, there's Aromacin, and Femara.
Femara.
Are the 3 that we're using now. And there's studies that are prolonging the treatment of these on beyond the 5-year point. But standardly, basically now, we generally go 5 years and don't go beyond 5 years of treatment. Follow-up, though, goes on beyond that. We often follow our women out to 10 years and sometimes longer in certain cases.
How important is exercise to prevent relapse?
Well, there have been some studies. I mentioned the dietary study, which is a pretty good study, which implied a healthy diet makes a big difference. The studies with exercise are not so, I guess, defined as that. Mm-hmm. There are studies showing that young women who exercise have a less incidence of breast cancer than those who are sedentary. But once a woman has breast cancer, what is the role of exercise in preventing a recurrence? We don't know. We do know that exercise helps that woman tolerate her treatment a lot better. Less hot flashes, less arthritic symptoms, tolerating the chemotherapy with less fatigue. So exercise is important in tolerating the treatment a lot better.
I saw recently that colon cancer may be fighting, or the effects of colon cancer may not show for those who exercise more than those who don't. Dr. Warlick, did you have something to add with that?
No, I was just going to say, I always tell my women every time the women that I treat when they're leaving, I say, what are you doing for your exercise? Because it is hard when you look at these studies to really show a benefit, but there's enough sort of across the board that are showing a benefit. Plus, it helps with the emotional issues, with depression that can be a part of this diagnosis. Yeah. It helps dealing with all the other psychological aspects of it. Plus, there's the other good health benefits. You know, we should be telling everyone in this country they should be getting more exercise than they do.
More so than ever.
Yeah.
All right, let's go to Lincolnton with Julia. Hi, Julia.
Hi.
Your question.
Well, I've been doing mammograms since age 24. My sister died at age 40 from breast cancer, and I had both breasts removed. And what I was questioning is, when I did my mammogram every single year, nothing showed up. And then my doctor, she felt a lump, and then we had it tested, and it was positive. I was a stage 3 with a fast-growing cancer.
Wow. So by the time they discovered the cancer, how far out was the mammogram?
3 weeks.
Okay. So your question is, how common is this?
Yeah, and how can they miss it? I mean, it was a big place.
Sure. Who would like to take that?
Well, those are always tough issues. I mean, the mammograms are not 100%. They're not perfect. Yeah. But I think they are still showing us that we are catching the disease earlier in a lot of women. But you still need to do self-exams. You need to bring any new issues to your doctor with nipple discharge or bleeding. All those things are important parts of it. And breast cancer does take on the full gambit. And so sometimes they can occur very quickly. I'm glad to see that you're doing well, though, now, and that's the most important thing. And so that's the good news.
Right. And hopefully your message can be passed along to others that in addition to being tested, self-exam is so important this day and time.
It's still a part of the one of the things we can use.
Sure. Okay. What are so-called protocol treatments? Dr. Warlick?
Well, protocol treatments are what we believe is the newest best treatment. And so as I went over some of those slides earlier, looking at the breast conservation trials, women enrolled in a very standardized treatment approach so that we can compare newer treatments with what we feel is the current standard. And by doing that, not only is that woman being able to get what we believe is the most cutting edge treatment, but they will also help future women with breast cancer. And so we all are actively trying to encourage women to participate in these trials because it will be a big advantage and very important for future women with breast cancer to get the best treatments that we can.
Dr. Boyd, in 15 seconds, how do we wrap this discussion up? There's hope out there.
There's hope, and I do want to add that breast cancer is a multidisciplinary approach. Back in the days, 20, 30 years ago when I was starting my training, the surgeons did their thing, the medical oncologist did his thing, radiation oncologist did her thing. But now we come together as a team because it involves all modalities, even with the earliest stage. And we can't be isolated as specialists. We have to come together as a team, and we're doing that more and more. And I think it helps me learn a little bit more about the other specialties, and it helps the patient.
We have some websites for you to go to for more information with October Awareness Month when it comes to breast cancer. There you go. For a free pin, you can call the 800 number 972-9451. We also have some more information for you, breast cancer awareness on the web at www.comencharlotte.org, walk.avonfoundation.org. We thank you so much for tuning in. As always, we hope that this show, this broadcast, has helped you become more health-wise. I'm Joey Pop. Good night.
If you would like more information about the guest on this HealthWise program or like to know more about next week's topic, please call the HealthWise information line at 704-371-8836. Email us at healthwise@wtbi.org or by regular mail. HealthWise, care of WTBI, 3242 Commonwealth Avenue, Charlotte, North Carolina, 28205. If you would like support group information about tonight's topic or any HealthWise topic, call Support Works at 704-331-9500. If you are interested in being a guest on HealthWise or like to sponsor a HealthWise program, please call Suzanne Milkey at 704-372-2442.
Learn more about HealthWise and other local productions at WTBI.org. Go to our website and you'll see current and upcoming events on air and in the community. That and much more at WTBI.org.
This HealthWise broadcast is made possible through a corporate contribution from AstraZeneca and by the Mecklenburg County Health Department and by viewers like you. Thank you.
This is WTBI.